Welcome to the Feeding Our Young podcast, version 2. Have you ever heard the phrase, nurses eat their young? Or sourdough? Feeding Our Young is more than a podcast. It's a movement. It's a desire to see new nurses of all ages, even the ones that are like 90 or maybe starting out at like 6, be supported and uplifted by their peers. And it starts with me, and it starts with you, and a really nice loaf of sourdough. So join host Eric Miller, registered nurse of nearly 20 years and adjunct clinical instructor, and today's honored guest, me, Amanda Shafer, and be ready to have your life uplifted so you can in turn uplift others. This is my part. Welcome to Feeding Our Young podcast.
All right, we are. Hopefully, you guys have stuck around and listened to the full second intro. Because if you haven't picked it up by now, if we have double episodes and the rare triple episodes, sometimes we just record other intros and do different things with it because it's fun. So if you skipped this second episode's intro, stop listening to me, go back, listen to the whole thing, because that was amazing. I'm not even going to tell you what Amanda did. She did great. So welcome back, Amanda Shafer. How are you since I last talked with you?
Oh gosh, I am doing fabulous.
Good.
I still have more projects to do.
Good. No twins though, and no more sourdough in the oven nothing in the oven, proverbially or literally.
Either way, right now. So I think we're good.
All
Those
right.
timers will not pop.
Clearly established. All right, so we're just gonna jump into this because I know we have a lot to talk about. I guess you ended the last episode on a really nice note as far as being a nurse for, oh my goodness, over 18 years. Like, you are so old. And ladies and gentlemen, she became a nurse at like 7 or 8 years old. Child prodigy. It was amazing. So no, it's just, I guess my first question for you is, what does it feel like now that your nursing career is literally an adult? Because it will become an adult in January, but it's not there yet. I'm still kind of in those late teens. So what does it feel like being a literal nursing adult now?
I mean, I don't think I really want to be an adult. There's a little bit more responsibilities there. So I'm just going to be in denial for a really long time.
I love it.
Really, nursing is one of those careers where you're constantly learning. So, and I feel that if you don't feel like you're still learning, it might not be the right career. It's a medical career that, it's ever changing, and doing this for this long and each new thing that comes out, I think, is still making it more and more interesting for me. So yeah, I think that's probably why nurses probably one of the longest fields. People don't usually just go to retirement age and retire. They're at it for quite a while. Yeah. Or they have no other choice. It's going to be one or the other.
That's it. That's when you get this far, that's it. You're in one of those two categories.
This far, you're just stuck.
And to clarify, I mean, you're not referring to official education, although that can be part of that, but just constantly learning, right?
Yeah, the field just constantly changes while you're in it. Something that you might have done a certain way 5 years ago has evolved, has changed. You're doing something different each time you're doing basically anything in nursing. New equipment comes out, new ways of doing things comes out. Mm-hmm. It's a constant learning. New diseases, new infections, new cures, it's just so many different things that go into it. So
yeah. And do you find that I've established this more than once in the podcast, but I genuinely feel like it's odd. It's almost a paradoxical thing where in our career we face some of the most rapid changing newness, for lack of better terms, and yet I feel like many of us are some of the more resistant folk to change. I mean, everybody is to a certain extent, but how is that even a thing? How are we no, we've always done it this way. Why are we doing it
Right. It's those that have, the longer you've been at it, it's like, oh, we used to not do it that way before. It always worked before. Why are we changing this now? And we do. All of us do. Even those that do some of those changes, there's still some things we're a little resistant on. Yep. Well, this worked before. Why do we have to change this? Feels like it's making it a little bit harder. And then the more you do it, you're like, oh, actually, this is okay. We
And
don't embrace that change right away.
exactly. It might take a little bit longer, if not at all. So, no. So what to foreshadow what's coming in the episode? There are some things that never change, and those are timeless principles. Those are those key, like you talk about code of ethics, patient safety, all the things. So
Yeah.
we're gonna circle back around on that. But in the meantime, we're at the perfect springboard for 18 and a half or so years of nursing. What have you done? Have you been a labor and delivery nurse your entire life?
Oh gosh, no. So I started out my career working in um, a medical clinic. So they had family practice there. They also had quite a few specialties that came in that I got some exposure to. Um, Cardiac urology, uh, obviously they had gynecology and OBGYN there too. So there's,
Mhm.
multiple GI, lots of specialties that came up into that area. And my job as an RN initially was a triage nurse there, but then I also worked with all these different providers in their specialties. So it gave me good experiences, learning all these different things in that clinic side of it. And then from there, I went to hospital nursing, and I started out in a med surge, and I wasn't actually on med surge for very long when the opportunity came up for me to apply for a labor and delivery position. At that time, you had to be doing med surge for at least 6 months before you could even apply to a labor and delivery position. It's a small rural hospital, so you needed to have experience in some things before they would start training you elsewhere.
Yeah.
Um, and I applied to labor and delivery, but I also applied to ICU at that time. Um, yeah, it was great. And my first week of labor and delivery orientation, I actually almost switched to ICU. I had a very hectic first week of, we'll just say, patients and diagnoses at that time,
Okay.
that I kind of came out of a room going, is every situation like that? And my preceptor at that time was like, no, that's just special. And I was like, okay, because I was just about to take the other position then, because I was not going to be able to do that
Like,
every
no,
single time.
thank you.
Like,
So,
no.
but to clarify, you were going to go from labor and delivery to the ICU. Like, that's some big step down.
Well, no, not quite some big step down, just kind of the other focus of where my brain could go.
There you go. There
Um,
you go.
if I had the two choices, these would be my top choices.
Yeah.
I worked labor and delivery at that hospital for like about 8 years. At the time, I also picked up ER shifts. I worked a
Mm.
lot of extra um, before moving on to Providence.
Mm.
There was a 1 year time span in between that hospital nursing and Providence's nursing for labor and delivery that I actually did a different type of clinic nursing, which was respiratory
Oh,
in an
wow.
outpatient care setting. So I was learning about CPAPs, oxygen, BiPAPs, non-invasive ventilators for ALS people,
Wow.
COPD people, um, going out doing home visits on them, assessing them and their respiratory status and what they need, and setting those things up. So I did this kind of multi different fields of nursing,
Yeah.
but in a way, it
Yeah.
helped me learn a lot, and there was a lot above just labor and delivery that I could apply in my own practice with patients. And labor and delivery isn't just having babies anymore. It's a very
Yeah.
complex field with lots of different patients who have different complications,
Hmm.
and being able to handle those different complications is, I think, what helps me out a lot.
Amazing. I appreciate you like sharing that because everybody listening is already well established. Nursing is one of the greatest fields on earth. We'll defend it to our dying day, and especially one of the qualities is because so much lateral movement. You can go here, you can go there, you can go wherever, you can do whatever. So I mean, here's Amanda's career: outpatient, inpatient, back to outpatient briefly, and then inpatient, and at no time, like it doesn't sound like You're not being forced out of these things. You're just, by their life circumstances, something, a change in desire, me, peds-onc, all my career. Oh, wait, now we're going to pivot and get into women's health, get into postpartum, which...
Which is the hard thing to do as a guy anyways.
Oh, for sure, for sure. But it's hilarious that you're talking about the clinic and all the different like specialties you had in your clinic. And it just brought me back to one of my very first job, absolute very first job in my life. 14 years old, got paid under the table, totally illegal, whatever. I don't care. I appreciated it. Didn't really do well with the money, but that's okay. I spent it because I was 14 years old, right?
That's what you're going to do at 14.
But I was a janitor. I was what is now referred to often as environmental services. But back then I was just a janitor and a 14-year-old one at that. And would you like to know of all the specialties that we had? And it was an outpatient clinic, same thing. ENT, family practice, all the things. Would you like to know what my primary unit that I always had to start my shift on was?
Oh, please.
OBGYN. As a 14-year-old,
the dirtiest unit.
ridiculous, nerdy kid, I'm coming in pretty much at the end of day, right? Like they're closed and doctors are wrapping up, nurses are wrapping up. There's not really patients anymore. I am emptying bags of vaginal speculums. You know what I mean? Like dumping this stuff out and all that. But there's a serendipity and an irony to that. Here you go, full circle, 30 years later, and it's like, oh, okay, maybe that was, I don't know, God's sense of humor. I'm not sure. So
at the same time, you can also appreciate what those people do for cleaning up.
Absolutely, 100% do not. And ironically, this is Environmental Services Week. So,
I know.
I don't care when you're listening to this. Well, you thank those people because, oh my goodness, I love them so much. And I actually was talking to Marina about this just this last week. I'll name drop. She's one of the most amazing environmental service techs that we've ever had. Just always positive,
that
always
must
smiling.
Be a day shifter. I have a night shift one that I love to death. Her
know
name's Mary.
There he is. So we got Mary.
Yeah.
So that's what I mean. I mean, it's like just thank everybody because we're all a freaking team. And again, anyway, this is one of those squirrels we were talking about. Woo! Undiagnosed diagnoses taking over. Let's pull this back around, shall we? So, Amanda, you talked about these two different reasons why people end up being in nursing for so long. I don't find you as being one of those ones that were forced to stay in it. So, your passion for nursing and your love for nursing is evident. What do you love about nursing?
What I love about nursing, so besides the constant learning, I mean, I do like that you can it's a field that you can constantly learn in. I think that for a lot of us, nursing is more of that calling that, we have it in our heart to want to care for people, to help them through their good times, to help them through their bad times. You have to have a sort of a passion for people. And I usually say this, that it's just, you have to have compassion for them. You need to be able to understand that everything they're going through, there's something behind, but at the same time, you can be the one to help them. And to me, that's like a feel-good thing. Even your most challenging patient, you can still find good things in that too. So nursing, while difficult and can be very frustrating and tiring at sometimes, is also very rewarding.
Yeah, very much so. And that is the primary reason I feel like, you know what I mean, that we'll defend this career to our dying days, because it is just, despite the challenges, and not even despite, I think sometimes because of the challenges, we get, it's just so rewarding. And I try to, you can't convey it. I try to convey it, and nursing students who are listening, I try to convey it to my nursing students. You don't see my face while I'm talking about this. You don't see that. You hear the passion, but you don't see the passion. Even my nursing students see it, and I still think I do it such a disservice because it is so rewarding and so life-changing. And so, man, I'm not
saying
glad.
You're not going to have those times where you get in your car and you cry. Everybody has that. I mean, you see all the videos online that, well, the stock room's the crying room. That's where you're going to cry. Well, no, you have tough times. You have tough challenges. But, if that's your passion, the nursing field, you find which part of that nursing field is your passion for you, and you find your ways to deal with your tough days.
Yeah.
Or go in the room and cry, and we all feel for you, and we know it, and come on out, we'll start over again.
But that's part of dealing with the tough days, right? Like
Right.
that's
Yeah.
it. That falls under that umbrella.
And I think when you first come to it, there's those tough days do get you pretty good. For a
Yeah.
lot, I've seen a lot of newer nurses come out and they have those tough days, and it's just like, I don't know if I can do this. Like, you can do it.
Mm-hmm.
You're good. You can learn this. You're doing a great job. Is providing them with those positive things, and then they have to find their way to work through those tough things.
And that's why this exists. Is we're
Right.
trying, you know what I mean? Trying to not allow the death of a nursing career before it even has a chance to get started.
Right. Yes. Having people just, be those encouragement for them. Like,
Yeah.
be there to, hey, yes, this was tough. This is the type of situation that's very tough and it hurts and it sucks. But here's all of the good things that you did.
Yeah.
Or even the mistakes that we make. I make mistakes all the time. I make mistakes at work, but we
I'm sorry,
learn from those mistakes.
Hold on one second. So wait, you make mistakes. What is that?
Okay, wait. Hold on.
Mistakes? Mistakes.
That'd
I've
be
heard this word before. I don't know. What does that mean? I don't understand.
We do. We have all made those mistakes on the job, and they can feel like something that's minor.
Let's do this right now. We're going to do this right now. This is fun.
Oh,
okay,
no.
So you, would you mind, and I'll reciprocate after you, of course, because I want to see how bad yours is. But do you have a story of a med error that you've made or a mistake that you've made that still bothers you to this day?
I do.
And are you willing to share it?
I do. I'm going to start with, because of that med error. Recently, I was actually able to help somebody else through that exact same med error.
Wow.
I mean, not perfectly the same, but the same type of medication and the same type of fear. So it would be with a labor patient. Mm-hmm. And labor patients have babies in their tummies that respond to lots of different little things. So you have two patients, mm-hmm. and one of them can be a little bit harder to get to and harder to take care of. So it always has it in the back of your mind that, that's your harder patient, is the one inside.
Yeah.
Because it's not that easy to care for. But we use a medication, Pitocin, for augmenting labor, helping contractions along, helping a person get to complete dilation so they can have their baby. And I was staying over and working extra to help out on the unit, and I had taken over a patient, and on the IV pump, we use LR for hydration fluid, or if they have a epidural, we also use it to mm-hmm. help with that. But she was also on Pitocin, and came about that she needed a bolus of kind of like D5-LR or D5 normal saline. But because of the way I had my lines hooked up, mm-hmm. I thought I was bolusing this D5 that was hooked up. The pit was bolusing. Mm-hmm. And the patient had it probably only got, it may seem like a small amount, like less than 10 mils, but that's a lot of pit mm-hmm. in a short little area. Because you think about it, we started out at 1 milli-unit a minute sort of thing. Like, it's really, really a small amount, but it's enough to cause a uterus to go into a tachysystole point where the baby's not getting much oxygen, and babies can get decels. And my patient had a very, I'd like to say, a very prolonged contraction of that uterus clamping down, and that baby responded to it with a large decel in that short time frame, and that clued me in. And I looked up and I stopped that pit, and yes, can I treat it? Yes, I hydrate her and give her a medication that's going to reverse that contractility. But you leave that room feeling like you're the worst person mm-hmm. ever, that you caused harm. That's what it feels like. And mm-hmm. technically, that is harm.
Yeah.
I wrote myself up. I contacted the provider. I felt awful. I told the patient what I did. This mm-hmm. is what happens. Because you take accountability.
Yeah.
And I just remember for weeks, I felt so bad about that. Just weeks. Didn't have that patient anymore. She had a great birth, everything else, but I felt horrible for a very long time.
Yeah.
And luckily, in a similar situation, Pitt was hooked up to a patient's line. And luckily, it wasn't started yet. But the tubing that was hooked up to this patient who was going very quickly was the Pitt tubing instead of just the LR tubing. And it was caught before everything was started, unhooked that, hooked up the other one. But that nurse felt so bad. And, she needed time to process that. But that time was like, let's talk about one of those times where you want to go to a crying room and you want to cry about it.
Yep.
She did, but I was able to go in and talk to her and say, I've done that mistake, but worse. And it's okay to feel bad, but look at this side of it. Yours was caught before anything could happen. And that's why there is, more than one person in there. This is why, we can double check each other all the time. Those mistakes can be caught.
Yeah.
And just kind of talking her through, but telling her my experience of what I actually did, I think helped her out of it too.
And that right there, like, I think the key point that Amanda brings out in this, first of all, if you haven't observed already, Amanda's still a nurse. She made a med error, a significant med error, and she's still practicing. Crazy how that works, huh? But more than that, I love what you say, like, about that accountability thing.
Yes.
Because here you are, you're an open book, and you were able to help someone through it, however long down the road, and be like, hey, guess what? You're not the only one. And that's the huge thing. The big takeaway is do not. So, no, I'm just going to, I'll go to mine. I did promise I would reciprocate. And this is the story I tell all my practicum students. I tell everybody, I'm like, it's when I interviewed originally to become a nurse, my very first interview. And I said, because they said, well, what's your, I don't remember if it was greatest fear and all the things. And I'm like, well, I said, unfortunately, I know that I'm a human and therefore I know I'm going to make a mistake. I said, my biggest hope is that it's just not a mistake that hurts or kills anybody. I recognize this there. I will do everything I can in my power to prevent that from happening. But when it does, and I tell people, it's when, it's not if. Yeah. When it does, then you learn from it. And I said, if I make a mistake once, man, I promise you, I will not make that same mistake again. And so then you fast forward a few years and I'm charged. So the takeaway from this is not, oh, Amanda stayed over and she was tired and made a med error. And I was charged and busy and made a med error. It happens. It doesn't matter what you're doing. So, but the long story short, I'll try and make this long story short because this is your episode, not mine. But this story.
Oh no, I want to hear this.
Oh my gosh. And I'm going to take it all the way back to actually very first quarter of SCC, community college as a nurse. And I'll never forget that instructor was like, I need you guys to know you're going to make a med error. Kind of the same thing, right? It's not if, it's when. And she said, I promise you, most of you in that moment will be tempted to cover it up. You'll be tempted to lie about it. You'll be tempted to whatever. Resist that temptation. She says, and I'm listening to her. And I'm a fairly straightforward guy. You know me. I try to be as honorable and all the things. Well, faithfully married, all the business, So in that moment, I'm going, okay. I'm logging it in. I'm like, that applies to other people. I'm not going to I'm honest about things to a fault. Not worried about it. So now you fast forward to this night, and I'm charged, and I had this wonderful teenager, and we'll avoid HIPAA information, but this particular teenager, so this is peds oncology. We give chemotherapy, and one of the chemotherapies has a medication that you give with it and then after it called Mesna that protects. The way I describe it to various nursing students and that sort of thing, or to patients, was it's like a Band-Aid for the bladder, the interior of the bladder, because this particular chemotherapy can cause hemorrhaging of the bladder. Long story short, so I go in, and this patient has a double lumen Hickman line and has a fluid line and then a med line. And I think they were separate, if I recall correctly. But as part of your assessment, you're making sure everything's connected, all the things. So both lines are connected. Life is good. I'm answering phone calls. I'm so sorry. Hold on. Blah, blah, blah. Yeah, da, da, da. So I was on near the start of my shift that I needed to give that first follow-up dose of Mesna. And then we would give another dose about, I think, 6 hours later. I think it was 4 hours. And so gave that first dose and we did other things. Came back 4, 5, 6, whatever, and gave the second dose of Mesna. And so now you fast forward, and it's middle of the night, and teenager patient, and all the things. And I had gone in the room for, I don't remember, it was like probably late night vitals. And, there's a weird smell. Mesna, for anyone who has worked with Mesna, it smells at times, it's been described as like, I describe it as like wet dog or electrical fire. It's got a very pungent aroma. I did not smell that night. I smelled like it almost, there was some odd smell in his room, but it wasn't Mesna. I knew what Mesna smelled like. So I'm like, oh man, like I'm not thinking, is his computer overheating? All the things. I'm sniffing his computer while he's asleep. The weird things we do at night, right? And he's
I wouldn't take it that far. No sniffing of the computers.
You haven't sniffed a computer at night? Come on. It's so fun, let me tell you. Anyway, and so...
You're trying to locate the smell.
I'm trying to I don't know, whatever. So he, while I'm in there finishing charting something, he rips a good one. And I'm like, well, maybe that's it. So I go out, and as we do with good teams, I'm like, hey, so-and-so, can you go double check this? And just, can you go in his room? And I don't know where the source is. I don't know if it's in the wall. I don't know if it's, you know what I mean? I'm really concerned about stuff. And she went in, she came out, she's like, no, she goes, it almost smells like he's passing gas, but not quite. And I was like, she was like, is he? And I said, well, I mean, he coincidentally did do one while I was in there. So that's probably it. So we leave it be. About an hour later, he hits the call light, and he's like, hey, Eric, I just want to let you know, I went to the bathroom, which I needed to tend to. But he's like, also, while I was doing that, I was barefoot, and he's like, there's something sticky on the floor. I was like, well, I'll take care of it for you. Get back in bed. Don't worry about me. Amanda, I still to this day, I click on my pen light, and I'm looking at the floor, and a white sheen. And this white sheen extends from my side of his bed all the way under his bed, passed through the bed, fortunately, because then he stepped in it. And I'm looking at all this going, what in God's green earth is going on? I cannot figure this out to save my life. And I'm like, what is this? What in the... So then you go through the critical thinking. And that's that and the other. Anyway, what had happened was his med line, which was on a syringe pump, separate from the actual fluid line, was coiled up. As I'm investigating what happened, I don't know at what point it happened. I swear still to this day he was connected, at least for that first dose or the beginning. But it was coiled up and hung on the clamp for that syringe pump. And it was just dripping onto the floor.
Oh, gosh.
And so I infused at least one, if not both doses of Mesna onto the floor. This is 4:35 in the morning.
The floor is cured.
Yeah. Oh, floors. Man, that floor is not going to hemorrhage. But no, so like you said, just
right.
Pit in the stomach.
Yes.
This particular teenager had already had bladder issues. And so oh my gosh, I'm picturing he's gonna, they're gonna need like surgery and ostomy, all these things.
You're hitting those worst case scenarios.
Oh, which is where you go. And I went to the restroom and I sat down and I'm close to crying. I'm shaking. I'm close to crying. And in that moment, how do I cover this up? That is what came in my brain. As honest of a guy as I try to be, that's what came in my brain. And I seriously, you're kind of playing with that one around a little bit. And it was like, no,
and you also what you're hitting in your brain. How do I fix this? How do I fix this?
Yep. How do I make this right? And I was like, nope, I got to call. So I called, and fortunately, the doctor was very straightforward. I love this woman to death. And she was like, okay, all right, well, we're going to need to, get another dose and let's give that dose and we'll do these labs, XYZ and all the things. Fast forward, again, my story's taken way too long. I'm going to have to cut some of that part out. But I get to the point where...
I like this
story. We're just talking to each
so
other.
Much better again.
And I wrote her an email and I said, Doc, thank you so much for not ripping me a new one. That was very hard, for me to go, and all the things. And I'm so sorry. And I promise you, I made that mistake once. It will never happen again. I still can't explain it. I don't know why it happened, but I can guarantee as best as I can, this is not happening again. And she wrote me back and she said, you know what, Eric? She goes, you know why I didn't rip you a new one? Because I knew you'd be beating yourself up. And it's time to stop. And, don't process that however you need to process it. Let it feel for it. Like you said, you know what I mean?
Yes.
Do what you need to do, but then let it go. You made a mistake.
Yeah.
Let's move on. They're likely not going to be hard. And fortunately, same thing. Like harm done? Potential for sure. And fortunately, there was no additional anything that, you know what I mean? Like all my worst case scenarios did not come true. So all that to say,
That
everybody.
biggest part is not having somebody, make you feel worse about it.
Yes.
You're learning from it.
Yep.
Having somebody basically say, here's the thing, you came forward, we worked on it, work on fixing it or treating or whatever you need to do. But it's having that accountability and not having somebody make you feel less because of it.
Yeah. And that's why and please make sure you're in an environment where you are telling, because same thing, I filled out all the things and filled it out on myself. But that's how we learn and that's how we teach each other. And you've got to be vulnerable and open. And again, in both our cases, in anybody's case who's made a med error, you got the rest of your shift to do. And
you gotta keep going.
That's the hardest part. Like,
Yeah.
how am I gonna, like, what? I gotta focus on, like, giving charge report? Who gives a rat's rear? You know what I mean?
I can't focus on anything right now.
No.
I just go back to the crying closet.
I'm the most miserable nurse on the face of the planet today, and I just can't. Yeah. Okay. I'm glad we had that discussion. Like, that
Absolutely.
was not planned. This was one of those unplanned things that we had for you guys. But that's it. Like, please take that away and know that it's not if, it's when. And be ready to be honest. Yeah. Be honorable, honest, open, teachable. And if you are in a place that shames you for that, or if you have coworkers that shame you for that, yeah, you gotta no. So on the subject of things that we're passionate about, I mean, I guess we kind of just circumvented, went all the way around a different way. Anything else you want to talk about your nursing career or anything like that as far as that goes before we move on to our next passionate topic?
No. I think my nursing career has been very fulfilling.
Yeah. Which is why you're still in it.
I kind of want to make it fulfilling for others that are coming into it.
Awesome. That's why I'm so glad you're here. So we talked about briefly about how nurses are most resistant to change, even though it is one of the healthcare, the healthcare field is one of those that brings about so many changes so rapidly. And yet there are things that we did mention that are timeless principles, patient safety, things of that nature that should never, ever change, and that you hope everyone has learned. And so the irony of Amanda coming on this podcast, I try not to be that guy at work. I'm not going around like, hey, Amanda, have you listened to the podcast? Hey, Amanda, when am I going to get you in studio? Hey, Amanda. So I don't do that. I don't do that to people. And
nope,
you know what I mean? Yeah. And that's on purpose. And so, and it's bit me in the, like Harley, when I talked to her, she was like, I was wondering when you were going to ask me. I'm like, I'm not asking anybody. I want people to like, just, if you want, come on. I'm nurse.
That's it.
Eric.
I better go get that princess crown and hand it over to Harley.
I love it. Doesn't she still already have it? I don't know.
Probably.
Anyway.
I don't know.
So all that to say, I'm not that guy at work. I don't do that. So when Amanda writes me out of the blue, she's like, Eric, I don't know. I mean, I've listened to some of the episodes. I haven't listened to all of them. And I know you've recorded a bunch more that haven't aired. And I don't know if this subject has come up. So if it hasn't, you really should talk about it. And in any good podcast host or coworker, their response to that is exactly what mine was. And it was, Amanda, it sounds like you need to come in studio. And so here we are. And we're grooming all
that's how you wrote people. That's how you wrote people in. I get it.
Yeah, it's weird.
Has this been done yet, Eric? Oh, but hey.
It's odd. It's almost like, I hear as one of my coworkers who's passionate about something. Maybe we need to speak to that to a larger audience. Come on in. Let's go. So anyway, no, like I said, I'll take anyone I work with. I'll take anyone who's willing to talk on the show, who's positive, who's got that same heart of like, let's just nip this eating our young in the bud. So that being said, this is kind of a different tangent. It doesn't have to do necessarily with eating our young, but it's super passionate subject for Amanda. And when she wrote me, I was like, oh girl, you can ask any of my former students. This is something that I hammer home. So what is this mystery topic, Amanda?
This mystery topic is consent.
Consent.
Absolutely, consent. So we are working with people, and these people, you need consent from them to do things with them. You need consent from them to touch them. You need consent from them to give them medications. There's so much involved in consent. But the reason I'm so passionate about this is even me doing this for 18 and a half years, there are times I forgot to ask those most important questions. And then there are times that it's reminding other people to ask those most important questions. And my biggest one is you can't just assume that because a patient is there, that everything you do with them, they're just expecting, or they could be expecting, but you still need their permission to do it. And I'm going to give an example here of, obviously the area I work in has some very personal spaces that have to be assessed very frequently. And in labor and delivery, that's going to be cervixes. That's inside a woman's vagina. That is very personal space. And even though they're there, they know they're going to have a baby one way or another, or that exams are part of it. It doesn't always mean they might be comfortable with it. It doesn't always mean that you can just go in and do that. In our labor and delivery triage, we have patients undressed from the waist down. Sometimes right when they come in, they have a sheet that covers them. They know they're going to get an exam. If I'm sitting there and I'm talking to them, finding out what they're there for, and maybe it's a labor check, and I'll say, well, part of finding out to see if you're in labor is seeing if your cervix is making any changes. Have you had one of these exams before? Some will tell me yes, some say no. If no, I explain. The ones that say yes, I'm like, so if you're okay with it, I would need to do this exam to see if your cervix is making change. And they'll say, okay. If I'm having them change at a later point, I'll step out, let them change, come back in. So even though they've already told me, okay, for this exam, when it comes to that exact moment, I ask them again. Before lifting up a sheet, a blanket, anything like that, once I have my gloves on, I say, is it okay if I do this exam? I've gone in rooms with providers, labor rooms, triage rooms, and they'll come in, they'll be like, I'm going to check your cervix. This is the part where I really encourage nurses, new nurses, old nurses, anybody. If I'm the one that's in that room, there's a fun little phrase that I like to say when a provider does that. And it is, what your provider meant to say was, is it okay if they do this exam? That's cluing whoever is doing that exam into, you need to ask. But it's not saying that in a confrontational way, it's reminding them. But it's also me being their advocate for that patient of, they still need your permission.
Yes, and like you said, this isn't a diatribe on, we need the down and dirty, Amanda. Who are the providers who never, this isn't anyone who's maybe happens to listen to this and is like, oh, is she talking about that incident or whatever? This isn't a diatribe on anyone because, like you said, we'll forget on occasion for whatever to do what it is that we need to do. Maybe in that moment, that person forgot. But that's what the patient advocacy is for. And I love that because I wanted to use that word back in first episode when you're talking about your son, because that's what foreshadowed this here. Because you're being an advocate for your own children, as we parents need to be. And now here you are, that's in your personal realm, and here you are in your professional realm. Nursing students, do not be afraid to speak up. I don't care if you've been on the job a day or 18 and a half years. You say, I know I'm new here, but can we? Or however you're going to do it, do not be afraid. Sorry, continue.
Yeah, those are the biggest. It's, there's nice ways and not nice ways, obviously. But it's not just, I don't want people to get stuck on, it's not just for something very personal, like a vaginal exam. It's for all the things too. I go in a room and ask a patient if I can touch their belly and adjust monitors. I go in a room and anytime I'm touching a patient, I ask their permission. I always ask, is it okay if I get a blood pressure on you right now? Is it okay if I change out your IV dressing? that is asking their permission. This is still their body. This is still their body that you're touching, and it's still their life. And you should be asking them if something's okay.
And you're valuing their life. As a pregnant woman, and as a woman who has taken care of numerous pregnant women, how often would you say people just touch your belly for funs without asking for permission?
All the time.
In society, let alone, you know what I mean? Like, oh,
Right.
you're pregnant. Like, what?
They just go to touching. And be like, oh, you've lost some weight. Let me rub your tummy. No. It's like you can't. Well, I mean, people do.
Yeah.
But once again, like we said, even those of us have done it many times. There's going to be times we forget to ask even on those minor things. And it was actually what reminded me to text you. That's what got me to text you about this. Is it was after a shift, and I went and I did my usual asking consent to do an exam on a patient. And this patient said to me, she goes, nobody's ever asked me that before. And I just sunk, and I actually apologized to her. I said, I am sorry nobody's ever asked you, but they should. They really should. My other thing is I'll empower patients. It's okay to tell somebody not to do something. It is okay to say, didn't you mean, can I check your cervix?
Yep.
Obviously, a lot of patients aren't going to probably speak up for themselves as much as having somebody else, like a nurse or even a provider, somebody in the room, just speak up for them in those types of situations. Yeah.
And that's why, so she writes me this, and I said, oh my gosh, Amanda, like I said, you don't even know. Because and I'm glad you brought out it's the simple things too, because that's what I preach on, is that it's, because everybody's like, well, it's obvious, you guys are in a very intimate, like, I don't have to do cervical exams. I'm in postpartum, but I'm a male nurse in a woman's world, and part of our job is assessing mothers. So I see breasts. I don't have to, but as part of the assessment, it is recommended that we are looking and checking for bleeding, especially while we're doing a fundal assessment, and that involves some exposure of areas of the body that our bathing suits cover. And so everybody's like, well, yeah, I mean, of course, you're a guy. I don't care if I'm a guy. I don't care if you're a guy. I don't care if you're a woman. I don't care if it's not like you're part of the sisterhood and the woman walks in and says, hi, I am going to do this to you. And they're like, oh, I'm great with you doing that. Yes, I'm great you're doing with it. You are a fellow woman. Come on in. Here, I am spread eagle. It's not, that is not what it's about.
No. And it's, it is a personal department. It's very personal. But if you think about that with anything, even if you're going in for a clinic visit, like I said, you ask them, is it okay if I do your blood pressure? I'm still touching you.
Yep.
It just asking permission, one, it not only is very appropriate and should be done, but it also helps your patients feel very comfortable, knowing that you respect them enough to ask their permission in order to do things with them.
Yep.
Go ahead. No, I was just saying it just helps build that confidence they have in you, to where if you do have to come up on something a little more tougher to deal with the patient, they're going to trust you to be able to talk to them, to be able to help them through multiple different things, because they've built that respect and rapport with you off just minor stuff or major. Yeah.
And it starts from the moment you enter the room. And that's what I've always preached to my new hires, my practicums, all the things, new students, everything. I'm like, the moment you knock on the door, you don't just barge in. Hopefully the curtain's drawn, and not everybody wants their curtain drawn. So you step in, and I even I'll go so far as to not totally look in. If I see that a curtain's not drawn, I'll look away for a minute and just be like, hey, this is Eric, your nurse, wondering if it's okay if I come in at this time. And that's postpartum, that's peds, that's whatever. You start there. And then, like you said, what I teach my students is you are invading somebody's bubble, whether you're touching them or not. If you were going in simply just to listen for a heart rate, you know what I mean? Like, hi, is it okay? This is what I'm planning on doing. Is this all right? And they have the right to say, no, thank you. Yeah. And everybody gets caught up on that. They're like, well, no, I have to get this fundal exam. I have to get these vital signs. I have to... No, I mean, I almost said it that way, earlier. Yeah, you don't have to. It's highly recommended. And the flip side of this, if I can just piggyback, before we close your amazing episode here, but we'll keep talking about this subject as long as we need to. But the piggyback on that too is informed consent, and you hear the term, and that informed in your mind should always be married to the word consent. Because then what happens is we have, especially, let's just use postpartum, labor and delivery, that sort of thing. There are medications that we highly, strongly, nearly 100% recommend that mothers take, babies take. There's injections we have to give to babies. Vitamin K, hepatitis B, for example. And some of the biggest sticking points are vitamin K and erythromycin eye ointment. And there's reasons why we give those, vitamin K in particular, because, babies need help clotting. We don't want them to have, brain bleeds and all the things. So, regardless of what you feel on whatever the position is, someone still can say no. And in the case of infants, in the case of peds, it's the parents who are making that decision for their children. Peds oncology, we have families who are, whether it's religious or non-religious reasons, refuse to take another person's blood. In peds oncology, where blood transfusions are given often like candy. So there's all these complicating factors that go into, and in fact, some things are so severe, we have them, you have to sign a release form. We have them sign a form, yeah. Yep. But the bottom line is they still have the right to refuse. I tell my families, I say, there's very little you can't refuse. If you decide you're not going to feed your baby, that is where we're going to have issues. I don't care if you're formula feeding. I don't care if you're breastfeeding. If you're not going to, and again, it goes back to basic patient safety. Right. But other than that, you can tell me not to do anything I need to do. And I will document it accordingly. And I'll go back on to my next patient. We'll just, you know what I mean? Like, yeah.
It is. And that informed consent is, it's not just like, not just when we're asking if we could do something and give consent, but it's also, here's your risks, here's your benefits.
Here's why we do this.
They know all these, they know all these different, and they get a chance to make a choice.
Yes.
You can get into, well, consent is implied. Well, certain situations, your patient is completely unconscious and they need to be coded and their heart stopped. Yeah, that's an implied consent. If they didn't tell you or have something written down that they're a DNR, that is an implied consent.
Yes.
That is a, we've gotten permission before to do certain life-saving things if you cannot make a decision at that time.
Yep.
And that's the only reasons implied consent is if you are not conscious enough to make a decision, then it is implied that we can do things to help you, get you back to a conscious state at some point, or tell a family member to make some sort of decision on something.
Yep.
Those are implied consent. Otherwise, everything else is informed consent.
Yep. Or absolutely should be.
Should be.
Absolutely should be.
Absolutely should be.
And that's what I love about the informed part of that too, is that you give the information, you educate your patient. Yeah. And I always tell my students, information is power. And so I say, Amanda, here's what we need to do for your baby. We need to give them vitamin K. And this is something we strongly, and that's how I phrase it. We strongly recommend it. You can refuse it. We strongly recommend it. And here's why. And I'll give them a brief little, here's why we do it. Here's the plus. And that, what's the possible risk? Here's, if there's a possible risk, we'll talk about that. And so it's that scenario. And then if after you've given that information, they still say no, done. We're not talking about it again. If you change your mind, please let nursing know. But in the meantime, I'm going to take this med off your thing. If there's a form, you're going to sign this form. Whatever. Right. People can leave. People can leave the hospital when a doctor says they shouldn't. Yes. The whole AMA, against medical advice.
Apparently it's not appropriate for nurses to leave AMA, though, but...
I still don't understand that, Amanda.
I don't know either. I signed the form. I had the doc sign the form. They still wouldn't let me out of my shift.
They say I should stay till the end of shift, a patient abandonment or something like that.
I believe that.
It's going to be too much of a workload on your peers. We'll figure it out. We're working on it, guys. We're working on it. So, all right. Anything else on this passionate subject, Amanda, before we wrap this up?
No, I just think helping people, reminding them, even, like I said, even our providers, even people that know they're going to have something done to them, you still ask.
Yep.
Still ask.
Yep. Maybe in that moment, option. It's a no.
Yeah.
Maybe it was a yes 2 hours ago.
Right.
And now it's like, well, I know we've done this, but no. Okay.
Yeah, exactly.
Yep.
And respect those choices.
Yeah. Even if they're not the choices you would make for yourself or for your loved one.
Our personal choices cannot affect our patients' choices.
Yeah, absolutely. I love it, Amanda. So you chose 3 words to describe nursing school. What were they?
Oh
and why
gosh, I
you choose them?
did.
I know. Let's go all the way. We're dialing it all the way back to sourdough days.
Oh, why
And
couldn't that be the word? I should have picked sourdough. I
oh,
mean, nursing school
okay.
can
So
be kind of
honorary
sour.
4th word. Honorary 4th word is sourdough. All right. No, it is. You know what? What were the 3 words you chose? Why did you pick them? And how are you going to make sourdough a descriptive term for nursing school? Go.
Oh, I got it. Okay. So time consuming. And I know it's kind of 2 words, but it is. It's time consuming.
It's got a hyphen.
Nursing school takes up a lot of your time and energy and things you have to put into it, but still doable. Which brings to the next word, manageable. Nursing school is manageable. It has hard points, it has easier points. And when you combine that with life, it's going to feel hard a lot, but it's still manageable. You just have to put it in the order that's manageable for you. Do the things that you need to do to make it manageable for you. And tiring. But don't worry, your whole career is going to be a little tiring too. Long shifts. Whether you work in a clinic, whether you work 8-hour shifts, 5 days a week.
Days or nights, it doesn't matter.
Days, nights, it is tiring. We can all get tired on our shifts. That's going to be with any career too. But nursing school is very tiring. You're absorbing so much information and you're trying to take in a whole lot, and then you're preparing for exams and you're learning so much information and technically what seems like a forever time, but it's also a very short time frame if you think about it. You get worn out. And those are the people that are like, I don't know if I'm going to make it. I don't know if I'm going to. Trust me, I still have life going on outside here too, and I've been a nurse for a long time, and it's still tiring.
Yeah.
But find those positives. There's ways to make that turn back around. You're going to have your moments. Do your de-stressing techniques. Whatever works for you to make it better. Grab your 10:30 a.m. mimosa for brunch. Those unhealthy coping mechanisms, no. Just find those things, but remember, that's only one day. That's only one space. That's only one time.
Yeah.
It'll change for you.
Go find your crying stock room or your crying bathroom. Yep. Go cry it out and come back.
Find your crying friend. You guys can cry together.
Yeah. Yeah.
And then,
awesome.
Sourdough. Nursing and nursing school can be a little sour. It can be a little sour. But at the end, that full product, it's good. It's baked. It's turned into its final masterpiece that can still have time for growing.
And it takes a bit of work to make it happen.
Work. Yes.
And what I love about it is
you can keep feeding it. Oh.
You can keep. No, you what can. I love. Well, you can. But that's what I love about it is that you hear about these sourdough starters that are hundreds of years old, and that's exactly what's going on. What's happening? You made sourdough
have to feed it.
Because you got your starter from somebody else. And in nursing, man, we are just generation after generation teaching the next one, next one, and passing hopefully these nuggets of truth along. Oh, sourdough.
Eric, when you feed your sourdough, it grows. Just like you feed your students, they grow. You feed your newer nurses, they grow. That's it.
Mind's blown.
Sourdough podcast.
Mind's blown. That's it. Yeah, second episode. Well, one of them will be titled "It's All About the Sourdough." It writes itself. See, my job's easy. It's fine. All right,
you're good. You're great.
Before we wrap up, and so many things you've already said could qualify for this. If you had one thing that you want nursing students, nursing students, one thing you want nursing students to walk away from your episodes and retain, what would that be?
I think it's just going to be, it may seem tough at the moment, but you're going to grow, and always treat somebody how you want to be treated. So ask that consent, care for them like you're going to care for yourself.
Preaching it. And as a bonus question, one piece of advice you want nurses, peers or otherwise, to walk away with, obviously other than some of the things we talked about, what would that be?
Don't be afraid to speak up. Just don't be afraid to you know, don't be afraid to say what you're thinking. Don't be afraid to discuss things with everybody around you. We are all teams. There
Yeah.
doesn't matter which initials behind your name in that medical field. You are all on the same level because you are a team.
Mm-hmm.
And the only way that our patients thrive, the only way they do well, and the only way we thrive as teams is by working together and having that mutual understanding of each other.
Yeah. And as you eloquently pointed out earlier, doing it with respect. Doing it in a respectful way so that you're not, you know what I mean? It doesn't put someone on the defensive.
That you're not putting that person in the crying corner.
Yeah.
For longer than they need to be because they're already hard enough on themselves.
Exactly. As you've already heard us talk about. Amanda, this has been the most delightful time. I can't thank you enough. There's no better way to spend a post-afternoon run than to just sit and chew the whatever with you. See,
the sourdough.
I almost,
I'm sorry, you don't eat it, but the rest of us are going to eat some sourdough.
Chewing the sourdough. Awesome. Amanda, have a lovely rest of your day, friend.
Thank you so much, Eric.
Thank you. Here's what's happening on the next episode of Feeding Our Young.
What do I love about nursing school? I like to share my passion for it. I guess when I was in school, what I remember is a lot of very tenured people droning on and on about subjects that they either didn't know about, didn't care about, had no interest in anymore. And they were so disconnected from what it was to be an actual nurse. And that's what I craved. And so that's why I want to share that. And that's why I think it's really important as an instructor, as an educator, that I'm still doing the work, right? I'm still at the bedside. I call that like my street cred because I'm actually doing that. And I can say, yes, this is reality and this is how you are a nurse.
Did you like today's episode of Feeding Our Young? Let today's honored guest know by emailing us at thanks@feedingouryoung.org. Also, if you're a nursing student, nurse, or a nursing instructor and would like to be featured on a future episode, please email us a few details about yourself at the very special email address mystory@feedingouryoung.org. If you have a question you would like addressed in a future Q&A episode, please send it to q@feedingouryoung.org. For all other inquiries, please email us at info@feedingouryoung.org or text us at area code 509-ALL-THEM, 509-255-8436. We're so excited to have you return to hear our next honored guest. Be sure to follow us on TikTok, Facebook, Instagram, and YouTube at Feeding Our Young LLC. Again, that's username Feeding Our Young LLC. Until next time, be encouraged and go find someone to encourage today.